our in-room participants, when you raise a question or answer a question, please hold down the speaker button in front of you and keep holding that as you speak. This session, we will have 3 speakers. The first speaker will be Dr. Megan Hyun, and Megan is one of the physicists in our physics faculty in our department. She's also a past AAPM president. She's going to talk to us about dosimetric review and clinical applications of velocity.
Thanks, Dan. So this is what I look like without my mask. It's not quite as handsome as Dr. Enk's photo, but hopefully it gives you a sense of what I look like under this. I don't have any relevant conflicts of interest to disclose, but I do want to mention that I'll talk about a few products in this talk, and it's just for informational purposes only. It's not an endorsement. So here's an outline of what I'll be talking about today. The topic of this presentation is dosimetric review in radiation oncology. So I'll talk about what that is and the motivations behind it. And then I'll go into the tools that we need to make it a reality and the available software to make this happen. I'll give a demonstration with the software that we use in our clinic, which is the Eclipse treatment planning system with Velocity. And then I'll talk about some challenges that we've encountered with this workflow and how we plan to mitigate them. So first, what is dosimetric review? Well, let's start by talking about what it isn't. So in standard of care radiation therapy, I'll outline for you the timeline of the patient's treatment. So first they come in for a simulation and we take a CT, and we can use this CT scan for treatment planning because we get density information from the CT numbers. And then once we're happy with the treatment plan, we enter into a cycle of imaging and treatment. And the imaging can happen before the treatment, during the treatment, after the treatment, just to give us a sense of whether the patient's aligned properly and what's happening with their anatomy and their body throughout the course of treatment. And essential to this is the physician and physicist's review of these images to assess how happy we are with the patient's positioning and anatomy. But if we're just looking at the images, we're missing an important part of the picture, and that's where dosimetric review comes in. So it allows us to take these images that we're taking on treatment and use them to establish what is the dosimetric difference between the delivered dose at treatment and the planned dose that we started with. And an implication of dosimetric review is that it allows us to eventually do adaptive radiotherapy, which is basically adapting the treatment plan as we see the patient's anatomy changing. And I'll talk a little more about this later. So why would dosimetric review be important? Well, if we take a treatment plan, as you see on the left here, we've gotten it to where we're really happy with it. This is a prostate plan. We've asked the patient to come in with a full bladder, and then the plan depends on that bladder being full. So this patient had an initial bladder fill of 343 cc's. And if we look at their weekly cone beam imaging, you can see from this animation that the bladder volume is changing dramatically throughout treatment. And we suspect that this is impacting the dose to the bladder, but we don't know exactly how much that dose is changing unless we're able to reconstruct it. And so I'm going to give a very brief literature review that shows what kinds of dosimetric impacts we're looking at. So the first example is in the prostate case, where you have all of these different bladder contours that we're treating with on a day-to-day basis. And on the right side, you can see a DVH that shows the wild variation in bladder dose as a result of these volumetric differences. So dosimetric review allows us to understand these dose differences and maybe act on them if we need to. In addition to the OAR dose, the target dose can also be affected. So this example is a liver patient. You can see the subtracted or dose distribution subtraction on the left, and then the DVH comparison on the right that shows that the liver target is undertreated if we add up all the treated doses because of geometric errors through the course of treatment. So both our organs at risk and our targets can be affected by these anatomic changes. And this shows why adaptive radiotherapy might be really important. So what is adaptive radiotherapy? Well, as I mentioned, it involves adapting the patient's treatment plan based on changing metrics throughout treatment. And this could be anatomical changes seen on imaging. It could be something that we see in a blood test that's changing throughout treatment. Really, the sky's the limit in terms of what we could adapt based on. But this talk is going to focus on these anatomical changes. So we can do adaptive radiotherapy in a few different ways. One is online. And in order to do online adaptive radiotherapy at the machine, you have to have a dedicated system that's all integrated with the treatment planning system in the machine. Most clinics don't have this capability. But if we want to do offline adaptive radiotherapy, then it's a lot easier for most clinics to do. And this requires regular monitoring of the patient's daily images and then adaptation between treatments. So what tools do we need to achieve dosimetric review and potentially adaptive radiotherapy offline? First of all, we need smooth and efficient image handling. Secondly, we need the appropriate algorithms. This includes both rigid registration between images and deformable registration, and the ability to create adapted CTs. And the reason these adapted CTs are important is that, as I mentioned, our simulation CT allows us to calculate our dose, but our treatment images don't. And so the adapted CT is a fusion of the two images that allows us to have the anatomy at the time of treatment with the density information needed to calculate dose. Thirdly, we need contouring tools, and the importance of this will be shown in the demonstration. We also need a dose calculation algorithm so that we can calculate the dose at the time of treatment. And lastly, we need to be able to display and compare doses as well. So there's three main ways of doing this offline. One would be most simply with a basic treatment planning system that has a deformable image registration algorithm. However, the disadvantage of this is that we can't create adapted CTs. We need a dedicated algorithm in order to do that. So some examples of this would be Eclipse or Pinnacle without any ancillary software. Secondly, we could take that basic TPS and add some ancillary software that allows us to create adapted CTs and do everything I listed on the previous slide. So some examples of ancillary software would be MIM or Velocity. However, the ancillary software doesn't have a dose calculation engine, which means there's going to be some transferring between the treatment planning system and your secondary software. And lastly, our final option is an advanced treatment planning system like RayStation, where you can do everything in one platform. But this is a really expensive system, so a lot of clinics don't have it. So let's talk a little bit about these different systems and the deformable image registration algorithms that they have, because not every deformable image registration algorithm is created equal. So what we've seen in the literature with both phantom studies and patient studies is that these algorithms vary in accuracy. So on this slide, I'm showing a patient study that shows that the algorithms used in Velocity can be inferior to those used in RayStation. And so as a user, we have to be aware of these limitations and be able to mitigate these in the clinical scenario. So what this image is showing us is in pink, the planning volume, and then in green, the volume at the time of treatment from the cone beam CT. And in yellow, we have the deformable image registration contour, which should match the pink line, but you can see in the top row that it does not match, and in the bottom it does. So this kind of showcases the difference between the two algorithms, at least for the soft tissue in the pelvis. And to look at this more quantitatively, if we look at the accuracy of the two types of algorithms in each of these different organs, we can see that RayStation is outperforming Velocity. So as a Velocity user, we have to be aware of these limitations in order to be able to use the software effectively. And this showcases the importance of evaluating every single deformation that we do in the adaptive process. So now I'd like to do a brief demonstration using our setup, which, as I mentioned, is the Eclipse treatment planning system with Velocity as an add-on software. And here's the basic workflow that we use. So we start by exporting data from the R&V system and the treatment planning system into Velocity. And then we use Velocity to create our adapted CTs. These adapted CTs allow us to then calculate the dose that was delivered at the time of treatment, which has to be done in the treatment planning system. And then we can take all of the doses for each treatment and add them up over the course of treatment. We call this the accumulation step. Before we analyze the dose, we want to make sure that we've evaluated our deformation so that we know the quality of the deformation that we're looking at, and we can reject any data that doesn't look good. And then we need to analyze the treated dose versus the planned dose. And this could be happening for an individual fraction or the whole course of treatment. So the first demonstration is going to go pretty fast. It's only a 1-minute clip, but it's going to show one of the workflows that Velocity has. And because it goes so fast, it'll show you how efficient this process tends to be. So what I've loaded here is a patient with a number of plans on their original CT, and then all those subsequent images that you can see down the line are their cone beams, and they already have online registrations from the machine loaded. So I'm going to start the navigator, and it'll guide me through the process. The first thing it's going to do is give me an overview of what the navigator does. It shows me what I need to have going into the workflow and what will come out at the end. And I apologize for the jumpy nature of this video. The next thing it's going to do is have me select the structure set. And then it'll have me select a few structures for QA. So these structures are going to be the structures that tell us how good the deformation was, and Velocity can actually give us some idea of the quality of the deformation based on those structures. Then it'll have me select which cone beam I want to use, and you can select multiple here, but I've just selected one. And then we'll select the online match from the machine, which gives us an initial rigid registration between the two images, and then it runs the algorithm. So once you have a deformation, as I mentioned, it's really important to assess the quality of it. So what you see here is the planning image, which is that larger image with the cone beam overlaid. And I'll show the basic process of evaluating the deformation between the two. And so we go to vector review, and I can add a displacement grid that kind of shows me where the image is being warped. This gives me an initial sense of where the deformation is happening. Second, I've added an animation so you can see that bladder changing in volume from the cone beam volume to the planning volume. Now the planning volume is supposed to expand all the way out to the blue contour. But if you noticed in that animation, it didn't expand out all the way. So that tells us that our deformation is not a good quality. But something that we can do about this is do something called a structure guided deformation. And so in this case, what we're going to do is I'll show you an animation of me doing a really bad job contouring a bladder. I apologize for that. And then we're going to tell the system, hey, this is where the bladder is on the cone beam, and you So once we have our contour completed, we can interpolate and then feed that into the algorithm. So this tells you why it's important that your process has contouring tools so that you can do something like this and mitigate the problems that we might have with the algorithm. The last thing that I'll show is once we have our accumulated dose distribution that tells us over the course of the whole treatment, what was the final dose distribution, and let's compare that to the plan. These are the tools that Velocity has to allow us to evaluate that. So on the left side, you can see a histogram of all of my organs that I've contoured and how much of their volume is at different dose differences. So the center represents a difference of 0, and then to the right, we see overdosing, and to the left, underdosing. And then we'll switch over to a dose subtraction view so we can see the differences between the dose distributions on the anatomy. So in this case, I've switched to a head and neck example. You can see on the sides of the face, we have pretty large dose differences. And that's because this patient has lost weight in the face over the course of treatment. And so if we're doing this dosimetric review on a regular basis throughout treatment, we can help mitigate some of these effects before it accumulates to this level. So now that we've gone through the process of doing this dosimetric review, I'll show you some sample results of what this might look like once you've completed the process. So I'll start with our head and neck cohort. So if we just look at organs at risk, some patterns that we've seen in our cohort is that as the patient loses weight and the tumor shrinks, we tend to see the organs at risk get worse over the course of treatment. So this just shows the mean parotid dose for all of these head and neck patients. And you can see that the effect varies from patient to patient, as you might expect, because the patient anatomy changes also vary. But for that patient shown in blue, we see a huge difference in the parotid dose across the course of treatment. So if we had been regularly monitoring this patient throughout treatment, we might have been able to intervene. Likewise, if we look at our target doses, we see a similar pattern, but in the opposite direction. So now we tend to undertreat our targets over the course of treatment. And this isn't true for every patient, but it is on the average true for this cohort. And so by doing regular dosimetric review, you can help mitigate some of these effects and adapt your treatment. There are some challenges though, and I've been hinting at this as I talked about our deformable image registration algorithm, but something that you have to keep an eye out for, especially with our prostate patients, is that this algorithm has some limitations when it comes to changes in bladder fill. So an example of this is shown here, where on the left side, we've done our deformation without any structure guidance, and then we've created this adapted CT, and you can see that this image kind of looks like if you took a prostate patient and put them in front of a funhouse mirror. The bladder looks really crazy in shape. It's added bone where there is no bone. So obviously we're not happy with this image. We don't even have to do quantitative assessment to tell that we don't like it. But when we add that structure guided deformation in, we get the image on the right, where the bladder shape looks a lot more reasonable, and so we can actually calculate dose on this image. And I will note that we would do a density override for the contrast. So in summary for this slide, structure guided deformation does offer some improvement, but as you'll see in the results, some of our cone beams still can't be adapted and analyzed. So this is an example of results from our prostate patients, where you can see a weak correlation between the change in the patient's bladder dose and the dose to the bladder. So you do tend to see a little bit hotter bladder dose as the patient's bladder becomes more and more underfilled. And then the red X's on the X-axis show patients where we could not perform the adaptation because the deformable image registration was too low quality. And so this really showcases why it's important to understand the limitations of your algorithm and try to mitigate them so that you can fill out this missing data. And this red bounding box kind of shows where we're trying to get to. So if we could keep our bladder dose differences from the plan to within about 10%, the first thing that we would want to do is reduce the change in bladder fill from day to day down to about 50% underfill. And that should limit some of that dose difference that we see. And so some ways that we've identified to potentially address these challenges include several interventions. So the first one that we've identified is managing bladder fill at the time of SIM. So you can see from the image, if your initial volume is quite large, maybe it's difficult for the patient to achieve that bladder fill every day. And so if we manage their fill at the beginning, then the level of underfill will be reduced. Secondly, we found that it's really important to make sure when you do the deformable image registration that you choose the image that has no contrast, because the algorithm really struggles when one image has contrast in the bladder and one doesn't to tell that they're both the same organ. Third, one of our therapists actually had the idea to add a threshold contour so that when the therapists are setting the patient up at the table, they can see this contour on the image and say, oh, our bladder is not quite up to that minimum acceptable level, so we won't treat yet, we'll fill the bladder and then put them back on. This gives them a really quantitative assessment of when it's okay to treat or not treat. And then lastly, this point is probably the most controversial, but maybe we can stir up a little bit of debate. So there's been some recent literature showing that physicists' consultations with patients can be really beneficial to the patient. They tend to reduce patient anxiety. I've written a paper showing that it increases patient autonomy from an ethics perspective, but I also suspect that patients may benefit from a technical meeting with a physicist to explain the importance of bladder fill, and if they have those meetings throughout treatment, it may improve patient bladder consistency and compliance. So this is just coming back to that outline showing where we've been today. We talked about the benefits of dosimetric review and why we might want to do it. We talked about the tools that we need in order to achieve it and what software is available to make this happen. I gave a demonstration with the system that we use. And then lastly, we discussed some of the challenges that we've encountered with this workflow. And I do want to acknowledge several students and residents who have worked on this project and just thank my clinical team for their support of the work, especially those who have offered helpful comments throughout the process. So thank you so much for your time, and I'll be happy to take questions during the panel discussion.